Hi everyone, my name is Lauren Burmann and I worked on this case study with my co-resident Hannah Russo. Today we'll be talking about septic submassive pulmonary embolism secondary to prosthetic valve endocarditis in the setting of severe thrombocytopenia. First, I want to go over a little introduction to pulmonary emboli and infective endocarditis. Pulmonary emboli can be classified into massive, submassive, and low risk. Treatment for massive and submassive include anticoagulation, systemic thrombolysis, catheter-directed therapy, thrombectomy, and IVC filter. Pulmonary emboli, specifically septic pulmonary emboli, can be a rare complication of endocarditis. Endocarditis is defined as an infection of the endocardium caused by platelets adhering to diseased heart valves and microorganisms circulating in the blood. There are several risk factors for this, and one that is important to this case report is IV drug use. The mainstay of treatment is source control with antibiotics and surgical valve replacement. Moving on to our case, the patient is a 28-year-old male with a history of prior endocarditis, pulmonary embolism, pulmonary embolectomy, and tricuspid valve replacement in 2016, who presented to the emergency department after relapsing 3 days prior with IV cocaine. He said after using the cocaine, he began experiencing shortness of breath with exertion, constant left-sided chest pain, and significant leg swelling. Vital signs on initial evaluation showed that he had a soft blood pressure. He was tachycardic and febrile at 38.2 degrees Celsius. Pertinent exam findings include patient being in moderate to severe acute distress. He was tachypnic, tachycardic, had 4+ edema from his toes to his mid-abdomen, as well as injection sites with bruising over his right antecubital fossa and forearm. Due to his presentation, labs and a CTA of his chest were obtained. Labs were significant for hemoglobin of 9.7, platelets 12, and a BNP of 1,821. His final blood culture results showed 3 out of 3 positive for group B strep. The CTA of his chest showed a cutoff of the right main pulmonary artery distally with extension of filling defects into the right lower, right middle lobe, and to a lesser degree, segmental branches. The right upper lobe was compatible with moderate to severe burden of right-sided pulmonary emboli. He was given antibiotics and consideration was given to administering heparin due to submassive pulmonary embolism and severe burden of right-sided pulmonary emboli. Several consultants were contacted to assist with the care and management of this patient because he was so complicated. We contacted hematology first, who stated there were no safe anticoagulation medications that could be administered due to severe thrombocytopenia and decreased hemoglobin. We then contacted the ICU, who came down to the emergency department to evaluate the patient, and their bedside ultrasound showed right ventricle dilation, and they recommended contacting interventional radiology for thrombectomy. Interventional radiology was contacted, and they weren't comfortable doing an intervention with the severe thrombocytopenia and recommended transferring patient to a tertiary facility. Ultimately, the patient was transferred to a tertiary facility where he had prior treatment for his endocarditis and valve replacement. So this case kind of introduces a lot of challenges, but especially for the treatment of his septic submassive pulmonary embolism while having the thrombocytopenia. The traditional treatment of pulmonary emboli with anticoagulation or thrombectomy was not indicated due to his severe thrombocytopenia. Severe thrombocytopenia can make management of pulmonary emboli challenging due to the increased risk of bleeding. After an extensive literature search, we found there is limited literature regarding the treatment of a septic submassive PE in the setting of endocarditis. There was one case study that we did find showing a patient with endocarditis and thrombocytopenia who received unfractionated heparin and platelets, which increased their platelet count enough for them to undergo surgical intervention. They underwent a removal of a giant thrombus vegetation, which ultimately aided in the recovery of their platelets. We concluded that additional studies would be beneficial in establishing guidelines for managing septic emboli and endocarditis but also with increasing platelet counts in patients with thrombocytopenia. Thank you so much for listening, and I hope you have a great rest of your day.